Hi, I'm Dr. R.J. Frasconi.
And I'm Dr. Bjorn Peterson.
And I'm Dr. Aaron Burnett.
Over the last year, we have taken a focused look on how we are managing the airway in pediatric patients. We have spent hours reviewing research literature, discussing this topic with local and national experts, and evaluating our own practices.
Ensuring the best outcome for our pediatric patients is the overarching goal that has motivated us as we re-examine what are the best practices in pre-hospital pediatric airway management. Both Dr. Peterson and I have children who live in the Regions EMS service area, and if they happen to become ill or injured, it will be an agency operating under the Regions EMS guidelines that responds to our homes. This makes this discussion even more personal for us.
We know that each of you share our goal of providing the highest quality, most evidence-based care to our patients. In medicine, as new data becomes available, we must continually reassess the way in which we practice to ensure that our interventions are safe, effective, and supported by the available scientific evidence. In the case of pediatric airway management, there has been a trend in the last several years based on scientific evidence and collective experience to move away from the use of endotracheal tubes.
We reached out to several national pediatric airway experts for their thoughts on this issue. Dr. Brian Moore is the state EMS medical director for the state of New Mexico and also the only state EMS medical director who is primarily a pediatric emergency physician.
Dr. Marianne Gaucher-Hill is the chief of the Division of Pediatric Emergency Medicine and the director of Emergency Medical Services at Harbor UCLA Medical Center in Los Angeles.
And Dr. Darren Browdy is the section chief of EMS and disaster medicine at the University of New Mexico. Dr. Browdy has experience as a street paramedic and also wrote the Orange RSI textbook that many of you read during your initial RSI training with Regions EMS. We will share some of their thoughts with you throughout this discussion.
Historically, pediatric endotracheal intubation was supported by the knowledge that respiratory arrest is the most common cause of pediatric cardiac arrest. It seemed logical that intubating children was in their best interest, as the most common reversible cause of the child's demise was respiratory. Aggressive pediatric intubation has also been the standard of care in the hospital. However, intuition without evidence is not always correct, and as medicine has advanced and new data has become available, the role of intubation in pediatric airway management has evolved.
A few years ago in New Mexico, we looked at this issue from an evidence-based perspective. What spurred this on is we had a number of cases at the university of field intubations in kids that didn't go well. And that was really the reason that we wanted to look at this statewide. And after doing a literature review, we went ahead and pulled it from the state scope of practice in New Mexico.
A few years ago, I was asked to participate in a debate with Marianne at NAMSP on pediatric intubation in the pre-hospital setting. And I was asked to take the pro position and Marianne, of course, the con position. And as I started preparing for that, which I thought was, something that I had believed in, just had always done, I, went to the literature, went to the data that I could find, and it quickly became apparent to me that I could not defend that position even in a debate.
We had a number of meetings, including street-level providers, and reviewed the literature and the data with them. And I'll never forget one of the people from Albuquerque Fire Department, a paramedic who's not academic, who he stood up and he said, "Well, why are we doing this?" And I said, "Exactly."
In recent years, evidence has been published that suggests that pre-hospital intubation in the pediatric population does not improve outcomes when compared to BLS airway management techniques. The largest study, conducted by Dr. Marianne Gaucher-Hill in the Los Angeles area, was published in the year 2000 and showed that there was no increase in survival, or more importantly, neurologically intact survival, in children who were intubated by EMS providers compared with those that were simply bagged.
There have been several additional studies which demonstrate that on average, a single paramedic only intubates one child every 15 to 20 years. Of course, these numbers are generalized, but the overall trends match our numbers locally here in the Twin Cities. Given the rarity of the procedure, it is extremely difficult for paramedics to maintain their proficiency in pediatric intubation.
What we are seeing overall, what I'm seeing at the Children's Hospital, the kids being transported, is most of these kids are being managed very well with bag valve mask ventilation. And they're doing a great job. And the kids are coming in pink with a good SAT, and that's what we're asking them to do.
I'm a big advocate of managing airways without intubation, in many cases in adults as well, with or without medications. And certainly in my own practice, if somebody comes to the emergency department in cardiac arrest without an airway or arrest in the emergency department, adult or pediatric, I do not manage that patient initially with intubation.
Not only are we not intubating kids in the field as much, we don't do it in the hospital nearly as often. We had a really busy, bad RSV year like most people this last year, and I didn't intubate a single kid. And we are the only receiving children's hospital in the state. And because we're just using all sorts of other techniques to not intubate.
There is clear consensus among the adult and pediatric emergency physicians we have spoken with that pre-hospital pediatric airways should be managed without endotracheal tubes. There are several adjunctive devices that can be used, but BLS techniques are the most important part of airway management.
So what about the kid with anaphylaxis, smoke inhalation, or airway burns? Many of you have raised these questions, and we appreciate your passion. We feel that these patients are extraordinarily rare, in most cases can still be managed adequately with BLS airway techniques, and are not worth the risk of widespread deployment and potential harm to other pediatric patients.
At the point that somebody tires out and goes into respiratory failure from an upper airway obstruction, they can usually still be managed with positive pressure ventilation. And I try to convey, and give the example that, stridor is something that's happening because we're creating negative pressure on inspiration. So people have an airway, they're inspiring, it's getting narrower. And then if that airway that's normally this big is now swollen and this big, and then they inspire, each time they inspire, it's getting so small that they're having to work so hard to breathe that eventually they tire out. But at the point at which the airway that started out like this is this big, when we provide positive pressure and stent that airway open, we can still usually ventilate those patients. Outside of a really unusual circumstance or a long transport setting, most patients, even with these upper airway conditions, can be managed with positive pressure through other means, whether that's through an extraglottic device or through bag mask ventilation.
When we looked back at all of our data in NumStars, we couldn't find any cases that actually made a difference. So people were wanting to keep a procedure in the scope for something we train for and we talk about, but really is never used in kids. I mean, maybe once every 20 years this might come up. And so the risk benefit of, maybe that one over what we were seeing of kids actually being killed by this, it just couldn't justify it.
The obstructed airway, is always potential. I think a system is more likely to see a foreign body aspiration, and so having the ability to do direct laryngoscopy and removal of a foreign body with pediatric McGill forceps, I think probably should be maintained, that equipment, although expensive, to have a pediatric blade. Even in a system like LA and Orange County, so we we're talking about a system that's so large. We basically have about 1 in 20 paramedics in the country in those two systems. Over 2.75 years, we saw 22 cases of foreign body aspiration, which removal, I think, of the foreign body was critical.
So what are your options for managing a pediatric airway? First, and most important, is good bag valve mask ventilation. Like Dr. Browdy mentioned, positive pressure ventilation will get you through many pediatric respiratory crises. Proper positioning and the use of airway adjuncts should not be underestimated, and this will get you to the hospital with a well-oxygenated child almost every time.
In kids over the age of 2, you could also consider placing a king airway, which would allow you to keep the stomach decompressed. Beyond that, we used to teach needle crike ventilation techniques, but like laryngeal edema, found this procedure to be extraordinarily rare. In fact, in 40 years at Regents Hospital, a needle crike has never been performed, which led us to remove the equipment from the emergency department and refocus our training efforts on basic airway management skills.
I think we looked at it, one of my fellows, and I can't remember the number, but it was extremely small. And really, it was in patients who were dead. And most of them were not children, which was interesting. When we looked at it, I think it was like 5 and 11 years. And so the issue is that do we continue, training on the skill? And the answer was no. We decided not to do that. So we don't do needle crike.
And interestingly, in New Mexico, needle crike was taken out of the scope of practice years ago. I think at least 15 years ago, if memory serves me correct. And when that was taken out, everybody was, really wondering if there were going to be some kids suffering as a result. And a lot of people said, you'll see there's going to be kids dying from this, and we're gonna have to reconsider this. And in 15 years, we have yet to have a case that has been brought forward where an otherwise survivable situation was not survived because we didn't have needle crike. Now, you can certainly wonder, when we take away intubation, is now there going to be some cases that do come forward, but that hasn't happened yet.
Some of the services carry the LMAs all the way down to a 5-kilo kid. But I was telling RJ is that on the receiving end, what I'm seeing mostly is bag valve mask ventilation, and they're doing a great job.
Even in pediatric hospitals, kids are being managed more and more without endotracheal tubes. There's not a single piece of evidence that supports the use of pediatric endotracheal intubation in the pre-hospital setting. With this knowledge, we feel that in the best interests of our patients, we can no longer justify maintaining pediatric endotracheal intubation in our patient care guidelines.
At Regions EMS, we have a tradition of expanding the scope of practice of our paramedics and EMTs. We were one of the first to deploy the Easy IO drill in the field.
Our medical direction team advocated for BLS medication variances with state regulatory boards so that EMTs could give albuterol, EpiPens, and glucagon.
We have given you new pharmaceutical options, such as ketamine, to manage patients with excited delirium and improve the safety of both provider and patient.
When the King Airway was deployed, we ensured that EMTs as well as paramedics could place the device.
Regions EMS was on the forefront of deploying intranasal medication administration.
We have advocated for TXA deployment with our SWAT medics and fought to obtain funding to equip our services with Lucas devices and CMAC video laryngoscopes.
This is the first time that we have made the decision to withdraw a procedure from our scope of practice. We did not come to this conclusion casually or without great debate, deliberation, and consultation. I understand that not everyone will agree with this decision, but we must put the patient at the center of this and every other medical decision we make.
I come from the streets. I am one of those people. I can remember, sitting in the ambulance bay trying to get a patient intubated because I wasn't going to be the guy that came in without the ET tube, or somehow thought that the patient was going to do better if I got that. And patient probably, I mean, surely in hindsight, the patients did worse because, we didn't know better, and we were focused on a skill, and we weren't focused on airway management. And so from a mature airway management perspective, I think we can all at least agree that we need to focus on airway management and not on any one skill.
Our goal is to do the right thing for our patients. We're our patients' advocates, and the facts speak to us, and they tell us that the best evidence says we should do bag mask ventilation on children in the out-of-hospital setting. And as that changes, we will move our practice to accommodate new information.
This is the course of action that we as the Regency EMS Medical Direction Team feel provides our pediatric patients with the most up-to-date, safe, and effective treatment.
We are always willing to discuss this and pledge to continually evaluate this issue as new evidence becomes available.
Thanks for your commitment to providing high-quality, evidence-based care and for respecting our decision on this issue.